Welcome to our educational video. This video has been developed by Mednav. Mednav is an organisation that helps to promote women's and children's health worldwide through education and innovation. If you'd like to know more about our work or indeed support us, please visit this website link.
In this video, we're going to talk about induction of labour, the process, the methods, and a bit about the research behind induction of labour and why it's important.
Having an induction of labour and delivery is like climbing a mountain, a rewarding, exhilarating challenge where reaching the top is the incredible moment of having your baby. Everything you've been working towards over the last 9 months, the enormous sense of achievement. Climbing that mountain is all about reaching the amazing view that you see from the top and that feeling of triumph. There may be different ways of reaching the top, pathways you weren't expecting, challenges you wouldn't have chosen, but nonetheless, when you reach the top, the view is awesome. The induction process, or the early phase of labour, is like the journey needed to get to base camp of the mountain. It is the first stage of the journey that all women need to undertake before they are in active labour, where the neck of the womb, or the cervix, dilates more quickly and you can see progress in your labour.
It's not unusual for induction of labour to take 2 days to get to base camp and then another day for your baby to come. We know that this can be a stressful process, so think about techniques you have learnt, people that make you feel safe and secure, or other things that help you to relax, and see how you can use those in your process towards base camp. There are alternative methods to get you into labour: sex, nipple stimulation, acupuncture, homeopathy, hypnotherapy and reflexology. And while at present there's no evidence that these get you into labour, they can be the sort of techniques that really help you feel relaxed, switched off, safe, secure, and they can help you in your process towards base camp. Your labour is described as induced if it is started artificially. You will be offered induction of labour if your doctor thinks it's safer for your baby to be born sooner rather than continuing your pregnancy. About 20% of women are induced. Methods and reasons for induction of labour vary greatly depending on you, your baby, your previous experiences, and a number of other factors. Before you can start the induction process, your baby will be checked with a monitor called a CTG. Your tummy will be examined and you will have a vaginal examination, as we will need to assess the neck of the womb, the cervix. Once the induction is started, you may have the opportunity to go home, or you may stay in hospital, depending on the reason why you're having the induction. If you do go home, then you should be given advice about when to come back to hospital. When we examine the cervix, we're assessing how ready your body is to go into labour, how your body is progressing through the early labour phase, or even the induction of labour. That is, how close you are to getting to base camp to start that climb of the mountain. We use a score called the Bishop score. A Bishop score that's high means you're almost there. A Bishop score that's low means that there's a bit of a walk to go. During early labour, the cervix changes from a long, closed, hard structure behind the baby's head to becoming thin, soft, moving forward and opening up or dilating. With induction of labour, we use different techniques and medication to promote these changes. Before your induction, your midwife or doctor may offer you a membrane sweep. A membrane sweep is when the midwife or doctor sweeps their finger around the opening of the neck of the womb. The membranes are the sac that surrounds the baby and hold in the amniotic fluid. During a sweep, the membranes are separated from the cervix to directly stimulate the production of prostaglandin, which may help you go into labour naturally. Membrane sweep reduces the time till spontaneous labour and reduces the need for formal induction of labour. It does not change the outcomes of delivery, and it does not increase infection for baby or mum. It can cause a little bit of pain, discomfort or bleeding, but overall, if we offer 8 women a membrane sweep, we avoid 1 woman needing a formal induction of labour.
Prostaglandin is a substance that acts like natural hormones to help kickstart labour by causing the cervix to ripen and may stimulate contractions. It can be like taking a more direct path to base camp rather than taking the scenic route. With spontaneous labour, where in the weeks before delivery you will have episodes of contractions which come and go, preparing your body for the big climb ahead.
Before using prostaglandin, the baby's heartbeat needs to be continuously monitored and the Bishop score assessed through a vaginal examination. Prostaglandins are normally given on the antenatal ward, but in some cases where the pregnancy is higher risk, it may be safer to give them on labour ward. The midwife or doctor will insert a tablet, pessary or gel into the vagina. The slow-release pessary looks a bit like a tampon. If you have been given a tablet or gel, then you will wait for 6 to 8 hours for your next assessment. The midwife or doctor will then decide if you require a further tablet or gel, or if you progress through the induction process and you're ready for the next stage, which is breaking the waters or the ARM. If you have a further dose, you will then wait to see if this brings on contractions for another at least 6 hours. If at any stage you start contracting regularly, you and your cervix may have dilated and reached base camp. You will then be checked for progress through a vaginal examination, and the baby will be checked with monitoring. After having a dose of prostaglandin, either the pessary, gel or tablet, your baby will be monitored with a CTG. This is to ensure that there are no problems with the baby associated with the prostaglandin. Occasionally, in up to 5% of inductions with prostaglandin, contractions can come too frequently. This is something we call hyperstimulation and rarely causes any problems for the baby. It's a situation that can be treated with medication or the pessary comes out, and the baby is unlikely to suffer any problems at all. If prostaglandins don't work at all and there's no change in your cervix, you may be offered prostaglandins again at a later stage. If, however, your doctor thinks it's safer for your baby to be born sooner, you may be offered a caesarean section. The optimum time for assessment is 6 to 8 hours after the tablets or gel, or 24 hours after the pessary. Unless you start contracting regularly following the medication, you will then be assessed sooner. Artificial rupture of membranes, breaking the waters, or ARM, can be used as part of the induction process or to speed up your labour if your labour is not progressing. So it can be thought of something to help push you up that hill past base camp. It can take some time to happen, as you'll need to be on labour ward for the ARM. Once on labour ward, your midwife or doctor will use this small, thin plastic probe, an amni hook, to break the waters around the baby, the membranes around the baby. ARM alone doesn't often get labour started. That's why it's not usually used as a method of induction on its own, unless there are specific reasons. It can be a little bit uncomfortable, so you may be offered gas and air to help you. The great thing about an early ARM in induction of labour is it shortens the time till your baby comes by on average 2 hours. Syntocinon, or Pitocin, is a synthetic form of the natural hormone oxytocin, which the body releases to make contractions. You will need to be on the labour ward with a midwife looking after you. The baby should be continuously monitored with a CTG. You will have a drip in your hand for the medication, and it will usually be given after the membranes have been ruptured. You'll be offered oxytocin if a membrane sweep or prostaglandin hasn't started your labour, or if you're having contractions but your labour isn't progressing. Once your contractions have begun, the rate of the drip can be adjusted. This allows contractions to happen often enough to make the cervix dilate without becoming too frequent. Oxytocin is started at a very low dose, and it is gradually increased to prevent the womb from overstimulating. Oxytocin is really great at bringing on contractions. They can be quite intense, as they've come on quicker than natural contractions, and your body has not had the time to adjust to them over the preceding week, as it would do in a natural labour. You can consider an epidural for pain relief if you wish.
Once the oxytocin is running and you are contracting regularly, the top of the mountain will be visible, and within the next day, you know you will reach the summit. The way up may not be straightforward. There may be unexpected hurdles, but the top is the top, and you will be rewarded with the greatest conquest, which is meeting your beautiful baby.
Occasionally, after prostaglandins, we can't break the waters, or even after prolonged periods of oxytocin of more than 12 hours, you're not in active labour. If this happens, you'll have the opportunity to discuss with your doctor what to do next. In rare cases, we'll look at the whole situation and offer you an induction at a later stage, or it may be that you're offered a caesarean section. It's not unusual for the whole process of induction of labour to take 2 days. There can be delays. This may be because you're contracting and we can't give you some of the medication we want to, or it may be because of the activity on the unit. If emergencies are happening, it can take some time to get to the labour ward to have your waters broken. In the unlikely event that you are the emergency, you definitely take priority. And throughout your induction process, your midwives and doctors will be looking after you and your baby to make sure that you are both safe. Post-dates, the risk for your baby is very small, but unfortunately, the chance of a baby dying in the womb or soon after delivery increases. At 37 weeks, at 0.7 per thousand, and beyond 43 weeks, it's 5.8 per thousand. Post-dates induction of labour also lowers the risk of the baby inhaling meconium, something we call meconium aspiration syndrome, which can make babies very sick. Another common reason for induction of labour is advanced maternal age. The risk is very low, but unfortunately, the risk of baby dying within the womb increases as the mother's age increases. The risk further increases if it's your first baby with certain ethnicities and other medical conditions. If mothers over the age of 40 choose to have an induction of labour at 39 to 40 weeks, this reduces their risk to the same as younger mothers with a pregnancy over 41 weeks. In this video, we've talked about induction of labour. We've talked about the process and also why we recommend induction of labour for post-dates baby. We've reminded ourselves that it can be a challenging process with twists and turns along the way. When you are going through your induction of labour process, think about the analogy of climbing the mountain. Think about people or things that make you feel relaxed, switched off, safe and secure, and think about how you can use them in your process to get you through past base camp, climbing the mountain, into that active phase of labour.
No matter which route you take up the mountain, whether you stride through each stage or have moments that are more challenging, you will reach the top and enjoy the great view. You should have an amazing sense of achievement because you have given birth to your beautiful baby.